Hello, everyone. My name is Shadi Reyes. I'm the co-host for this activity. I'm really privileged to be with esteemed speakers for this webinar. This is a series of webinars that DMC have put together to increase awareness of cardiovascular disease in the community for education, as well as to offer services to referring physician and as a showcase for what we do at DMC, the management of patients with COVID-19 and acute coronary syndrome. As you know, the MI or myocardial injury in COVID-19 happen in 20 to 30% of COVID patients and associated with increased risk for all-cause death. And this is with analyses we do what's called case fatality rate for COVID-19 remain low in 2.3%. However, in patient who has underlying heart disease can go as high as 10.5%, which is especially patient who had heart failure, valve problems, or blockage or coronary artery disease. So the mechanism for heart disease and COVID, either acute coronary syndrome due to plaque rupture, somebody has comorbidities, risk factor, smoker, hyperlipidemic, diabetic, or due to demand ischemia because of the stress that the body is going through. Microvascular ischemia also has been reported, include also an injury related to cytokine dysregulation and myocarditis. So as you know, as we came to know that this is more an inflammatory process, that's why there's an introduction for steroids, as well as the risk for steroids, as well as antibiotics and hydrochloroquines. But however, the most striking thing of the effect of this disease on us is the drop in the volume of patients coming to the hospital. It's not from the business perspective, it's more concerning from a public health issue. We have nationwide, as well as in the Europe, they notice a decrease in weekly volume of patients presenting to the hospital with chest pain, as well as a drop in the volume. As you see on the right graph here, this is a weekly drop during the COVID-19 between the March and May, which is a significant decrease that can up to 40% that affects and also has been reported to have a side effects down the line. I will show you through data. So how did we start this problem? Back in April 2nd, I posted a tweet on Twitter that's showing that we have noticed a decrease in STEMI volume in our lab. Where are these people are going? Not just pains anymore. Where are they going? And as you see here, from 500 plus patients, hey, there's a 50% drop in the volume in the cath lab. And nationwide, and these are from international and national volume. So we send this tweet along with our observation to European Heart Journal to tell them, like, are you seeing the same thing? And they ask us to write a paper about why this drop, and also to complement a paper coming from Italy showing the same observation. This is the hypothesis list that we came up with, but mainly things that kind of keep staying on top is patient are fear of coming to the hospital. They don't want to come here. They don't want to be infected, or if they are infected, they don't want to come to the hospital and infect others, or because they lost their insurance and economic strain on them or their beloved one. They don't want to come and overstrain the stress. Same thing we observed, we submitted a survey across like 12 cath labs in Michigan, one in New York and one in Kansas, about do you see the same observation between March and April 2019 compared to 2020? And sure enough, there was a 46% drop in volume across the state here in Michigan. And we published this data with a concern that where are these patients are. We still have the same risk factor of smoking. As a matter of fact, people are more sedentary now than ever before because of the social distancing and home lockdown. And that's the consequence we're going to see. We're going to see more and more paper coming on late presenters. This is a case we published about patient coming as a young guy, 36-year-old. Late presenters have acute myocardial infarction in the LAD, causing LV thrombus and acute decompensated heart failure. That was a kind of a consequence because he didn't come on time. So we wrote, again, multiple papers explaining about the pathology, how this happened, and what is the mechanism. But also, we would like to highlight a few things related to biomarkers. Do we need to trust the troponin? Is it still applicable and during COVID-positive patient? And yes, it is. It's a marker that there's a myocardial injury. There's a myocyte that's getting lost. And this is due to heart failure or myocytes or myocarditis. Similarly, the loss of either from inflammation or de novo plaque rupture during COVID infection, because ventricular arrhythmias, that VT or AFib was the main manifestation. And lastly, I'm going to do some comments on the medication. So how we manage these patients and in our lab, and also some consensus from different labs and guidelines. So this is a paper coming from Sky suggesting what is the best practice for COVID-19, as well as Jack published a guideline for management of these patients, as well as Jack intervention suggesting how do we manage these patients and how we triage them to minimize the risk of infection, as well as minimizing risk of jeopardizing the staff who are coming to the hospital. So at Detroit Medical Center, this is the way we do it here, or this is what we have been doing, especially during the peak pandemic. Single procedure room that dedicated for these patients who are confirmed to be COVID positive, or PUI, or patient under investigation. Negative pressure room, as well as we practice PPE very stringently on these rooms as well, as this is a standard of care. Already Dr. Terasaki and Dr. Zahar mentioned it already and covered it extensively. And also for patient, we did not bring every patient to the cath lab who are troponin positive. There is a triaging system where if the patient having a positive troponin due to what's called NSTEMI with no ST elevation, these patients can be managed medically, especially if the hemodynamic is stable, if the ST changes is not visible, or if they don't have any heart failure symptoms, or they are not in shock. These patients literally can be managed by anticoagulation, as well as a heart failure medication that's listed here with aspirin, P2Y12 inhibitor, statin, beta-blocker ACE inhibitor initiated early during the phase of the disease. These are algorithms suggested by the Societies of American College of Cardiology and Sky and American Heart Association, and how to identify these patients and put them in the cath lab, or try to put them in their locked room or quarantine, or bring them to the cath lab for urgency. As you see, the very high risk feature are somebody who has refractory chest pain, or somebody in shock, or life-threatening arrhythmia such as a VT or VF. For STEMI patients, a little bit different. As a matter of fact, some labs has been practicing thrombolytics in these patients who are stable, or people who has inferior infarction due to RCA infection. And then usually when this is patient completely healed from the infection, bring him back to the lab and do the angiogram to define the problem. So again, different practices, different suggestions, but we don't have enough evidence how the best way to treat these patients, but mainly prevention of spreading of the infection. The ACE inhibitor has been a debatable topic, but eventually there's multiple meta-analysis as well as single center analysis suggesting that there's no harm. As you know, there's a link between the ACE inhibitor and open the gate for the more spread or more infection. So if somebody was taking lisinopril, losartan, these medication don't increase the risk of infection. As a matter of fact, it causes more harm if you stop it on a heart failure patient. And similarly for other paper published as a meta-analysis from European Heart Journal. In terms of the safety and efficacy of hydroxychloroquine, which has been debatable for a while, we looked into meta-analysis, analyzing the data on what is the best practice and is this helpful or not. And because we have seen patients who are been on hydroxychloroquine, but they suffer from major arrhythmia. As you know, it's prolonged QT, it has a high risk for a VT and VF and sudden death. So, and sure enough, I mean, hydroxychloroquine offers no benefit in terms of decreasing the viral load. And you can see that on the first graph on the top compared to no therapy. And as a matter of fact, can increase the odds of mortality if you give it to patients who are COVID positive due to effect on cardiovascular system. So that kind of discouraged a lot of experts in the field to recommend routine use of hydroxychloroquine in these patients. And as a more effort to kind of spread the knowledge and also to explore the topic and learn more about it, there's a NACME, or National American COVID ST Elevation Myocardial Infarction Registry, which is Detroit Medical Center part of, is we are collecting data on all these patients who presented with ST elevation and how we manage them and what was the outcome. And if there's any collateral damage, such as increasing the infection in the staff and so forth, which is, I think so far there's a 200 center involved in the US, and we're going to include close to 500 patients, which is going to be presented next month at a national conference as a late breaking trial. With that, I would like to end with a few messages for physicians and other specialty primary care referring physician as well as patients. There is very little we know and too much to learn about COVID-19. Cardiovascular disease is still the #1 killer in the United States, and patients should not neglect symptoms such as chest pain, shortness of breath, indigestion, especially in women, swelling in the legs. This should be triggering you coming to the hospital to be checked. And COVID-19 should not risk for COVID-19 should not stop you, because heart disease might get to you before the COVID. Cardiovascular care at DMC is always available with best precaution implemented to prevent patients from being at risk for COVID-19 infection. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.